Welcome to Beyond the Practice. I'm very excited. This is a podcast where we are looking to bring together health and fitness providers who not only are experts in their field, but are wonderful at building a community around active lifestyles and good living. So today we are bringing on board a power couple who are doing amazing things with the physiology, with metabolic testing for longevity, weight loss, and performance. You guys are specialists not only in like the VO2 max, but you're doing stuff with menopause, you're doing stuff with hormones, you're doing all of these really cool things. And I am so excited to pick your brains today. We have David and Melissa Ambrose. Yay! Welcome, welcome. So I'm going to start with the question I always start with, which is, tell us your arc. Like what got you to this? Yeah. I know there's the long story, so we'll do whatever with that you want.
Well, it started with her idea. So
oh my gosh, yeah, the long story. I mean, the short version is that, you know, our business was kind of born out of exactly what I did in graduate school. But in graduate school, I was working with elite athletes, and which was great. But when I got out of school, that really wasn't what I wanted to do. So when the business finally formed, you know, we realized that our target market was not athletes. It was just your average person who wants to get healthy, wants to learn about their body, wants to kind of cut through all the noise that's out there. You know, and it took a long time for us to really get going. I think our business as it is right now has been about 5 years. But even within those 5 years, it's still kind of been, you know, figuring out, you know, kind of getting our groove. I would say probably for the past 2 or 3 years, it's been solid. We've, you know, we've kind of figured it out, but yeah, getting here, my gosh, we went through so many things to start this business. We've had so many other odd jobs. And then I don't know, somewhere around 5 years ago, I bought my first little metabolic machine and I was toting it behind me as a personal trainer. And I was like, we're going to make this business work. So
and we would go back to DC and run testing on our old clients. And it was just more of a part-time thing. And then
I did this kind of work for other businesses for a while. And, you know, it just got to a point where the way we wanted to do it differently. And I think that's where the business was born, was when we figured out how we wanted to do it.
And then also,
what was that different? What was the biggest gap that you were filling?
The biggest one that I've already said is a lot of times this caters to athletes, or when you think of VO2 max, you think of an athlete. And, you know, we wanted to tailor it to everybody. We wanted to make it so that everybody can do it. I've had an 84-year-old do a VO2 max assessment, you know, I personally spent, I don't know, a year or two kind of developing these protocols so that everybody can do it. And I think that was really what it was. Not that we don't love athletes. We get them. Testing them is fun. But they know about their body. And, you know, so getting somebody who really doesn't know and is really embarking on that journey for the first time and being able to explain to them what's happening and, you know, showing them all this stuff, that's really kind of where our passion kind of exploded. Was just kind of getting away from that assumption that you have to be in shape to do this. It's like, no, actually this should be your starting point, is this information. So I think that was the gap, right? The people that have kind of already in this realm, you know, if you look at their websites and you go to their places, it really does cater towards athletes. And I think that scares that can scare a lot of people off. It would scare me off. I wouldn't consider myself an athlete running a VO2 max assessment. So that's kind of how we looked at it, is, you know, if the average person is kind of feeling uncomfortable with that setting, we wanted to make it much more approachable and a much more friendly setting.
Absolutely. Maybe we should take a second and kind of explain what VO2 max testing is. And when you explain that, could you go into also what that would look like for a non-athlete? Because I'm picturing what we did in school, right? And that, it doesn't end well.
So any VO2 max assessment, the goal is to get you to your max effort, right? Your max capacity. VO2 max is the volume of oxygen at max effort. Max effort for everybody is going to look a little bit different. And so what we've done is, you know, we have a traditional bike and a treadmill that you can use. On the treadmill, we have a walk or a run protocol. So I think traditionally you run, whether you're a runner or not, you just run. And I can't do that. I can't just get on the treadmill and run. I would gas out super quick. So, you know, we have a pretty extensive conversation with a client before we do a VO2 max. What is your starting point? What are you comfortable doing? Most people walk. We have a walking protocol where you never have to run because we have a treadmill that goes up to a 30% incline. So you're walking up a hill. So we've got those types of protocols where everybody can do it. You know, regardless of whether you're an athlete or not, 2/3 of the test is very easy. It's a very gradual build. It's a very slow build. We purposely do that. We drag out what we call your aerobic zone on purpose because we're looking for some specifics, which we can get into later, but we've purposely made our protocol. So it's a very long warm up, a very long aerobic zone. And then that last little bit, that last little burst of energy that, you know, officially going for your max, that's when it's going to get difficult, no matter who you are, but it's designed so that anybody can get there. You can walk it, you can run it, we can cycle it. And it's just making sure that we start at a comfortable place for somebody so that they can get acclimated. You know, the first couple of minutes are super easy on the test. And then by the time we get ramped up and it's only 15 minutes long, you know, the coolest thing is seeing somebody who didn't think they could do it actually be able to do it and show them their capacity. Like they might say to me, I've never done cardio before and I don't do cardio. And I'm like, yeah, but look what you did do. So now we can, and we can kind of plan off of that.
Yeah. And people love anything that tells them something about themselves.
Yeah.
You know, it's all, I mean,
there's so much
to our advantage. And that's kind of a really, so what is it about that VO2 max that's even useful? Like besides it being this number or whatever?
Yeah, well, so, and we can get into, there's a lot of, you know, of assessments that we do and kind of what they mean, but the VO2 max, your volume of oxygen at max capacity, that's a normative data standard, right? We're ACSM norms, how healthy are your heart and lungs, right? It's going to put you in a category of fair, superior, excellent, whatever. That number we really just kind of look at as your longevity number, right? How healthy are the heart and lungs working together? I would say the applicable data that we get is we take a very close look at somebody's aerobic and anaerobic zones. So your aerobic zones being that low intensity, how well or when does your body burn fat, right? And then when do we switch over into that anaerobic zone? When are you no longer have enough oxygen coming in because you're breathing heavy. So now you're 100% carbohydrates, right? So we're able to look at your fat burning zone versus your anaerobic zones and go over them and say, okay, why is this important and where should we train for your goals? Because based on your goals, it's going to be different. You might lean on one type of training more than the other. You don't have to be a super endurance athlete to have a good VO2 max. You know, we've seen lots of people come in that are not runners, they're not cyclists, but they do other forms of activity and their VO2 max is great. So we look at those zones. We have about 5 heart rate training zones that we give people, and based on their goals, we say, you know, you need to train here, you need to train there, and try to make it something that's applicable for them and that's sustainable. So we give, you know, our cardiovascular recommendations are purely for cardiopulmonary health, right? How can we improve or maintain your VO2 max? How can we improve or maintain your body's ability to burn fat or whatever is going to help you with your goal?
Okay. All right. And with that, David, did you want to say something?
No, there's so much. Yeah, there's a whole bunch.
There's so much.
I'll talk about.
Oh, of course. Yeah. Yeah. I feel the VO2 max testing, certainly, you know, my experience was definitely the like, go get on the bike or go get on the treadmill and just go and go and go and go and go. And you're like, you've got the mask on, right? And you're just doing all the stuff and someone's yelling, like, keep going until you fall out. Right. So it is very interesting to think of trying to recommend that to somebody and be like, be prepared. Yeah. And it sounds like they're not getting that. They're not having to face that like massive thing which to an athlete is not that big of a deal because it's like, oh, I can do this.
And it's there, you know, the component of the test there, it's going to be difficult, but I think we ramp it up in a way and we make people feel comfortable in a way that gets it done. You know, the test is voluntary. I'm not standing behind you, you know, screaming at you and yelling at you.
Right.
And we do have a sub-max test available if somebody really can't get to max or, you know, if there's an issue there. But most people, I can only think of 1 or 2 times in our 5 years of doing it that somebody couldn't do it. Most people have been able to do it. And, you know, we really try hard to make sure that whatever fears they have coming into it, I think when everybody's done, they're like, oh, like that wasn't nearly as bad as I thought.
I'll say that wasn't so bad. But no, we've never not had someone to get in aerobic.
Well, I have, but that's keto. That's a different.
No, but I'm saying we've never not had someone complete the test where you can extrapolate VO2.
Yeah, that's everybody's gone.
So
You're always able to get the data.
Yeah. So even if somebody, so what you may see in some populations, if they're not used to getting their heart rate up higher and feeling that out of breath sensation where they're exhaling while they're inhaling and they're panting, at the end, as long as we get them to that point where they become anaerobic and 100% carb burning, we can extrapolate VO2 from that.
Yeah.
Right.
Yeah.
So,
some people just get uncomfortable in that situation.
And that's all it is they're not used. And it could be someone that's very deconditioned, a lot of excess body fat. They just don't do cardio, or they're not familiar with it. But I will say that in a 15-minute test, typically you're looking at probably a 5-minute warm up, a 2.5-minute cool down. So that is 7.5 is what's left. They probably don't become anaerobic until
usually 10
minutes in.
Yeah.
And if they're deconditioned, that's over after 30 seconds.
Yeah.
So really conversational the first 10 minutes, and then maybe they're not conversational. Like they have to really focus for the next 30 or 60. And then they say, I'm done. And they,
and as soon as you're done within minutes, you're fine.
Yeah.
It's not like it lasts all day,
So the protocol she developed is it's really her own. I mean, the way that she's developed it is so that anyone can do it. And the biggest we've had was someone who was 440 pounds do it. A guy wanted to be a firefighter.
Yeah, he was on our bike.
And our 84-year-old was our oldest. So we had do it. 82-year-old male who, when his wife had just passed, he took care of her for a couple of years and watched her decline and felt and saw his decline at the same time. So he's trying to get some of that back and make the next 10 years of his life better because of what he lost in seeing what his wife went through. So there's not an age limit. There's not as long as you can physically get on there or get on the bike. We had a guy that had a degenerative muscular disease. He wasn't able to do it. And that's the only person who wasn't able to do it because he doesn't have full use of all limbs. But unfortunately, and he tried to do it at his gym. And he's like, so that was the only time. Right, as someone who didn't have full mobility, right?
How do you navigate heart conditions? So what's your
as long as they're cleared by their cardiologist, this is what because people will ask us a lot. And my first question is, have you been cleared by your cardiologist to do high intensity work? That is step one. Or has a doctor or a cardiologist told you specifically not to go above a certain heart rate? Like those are red flags for us. But most people, even with whatever heart condition, most people are able to do it. We obviously do our screening. We have our waivers and our, our PARQs and everything that we go through. But unless you've been specifically told not to do that kind of work, it really hasn't been an issue. We have had people that have been on medications.
Is a problem.
Well, AFib would definitely be a problem.
AFib is told not to do it. Like we won't do that, right? Because
don't stress the heart, maybe.
Putting you in AFib is basically when
if you're on a beta blocker or another medication that lowers suppresses the heart rate.
There are some medications that will suppress the heart rate or suppress blood pressure. And again, as long as we know about it and you've been cleared to do that type of exercise, it hasn't been an issue. Now, how would you adjust for a beta blocker? Well, so as the technician, what we say is, if this is your norm, we're going to go with that, right? So we don't necessarily adjust because I want to know what they can do. So we say, if you can't get your heart rate above 150, if that's your max, that's what we're going to roll with because that's what you can do outside of here. So we don't necessarily adjust for it. We just take whatever your norm is. If this medication is your norm and this heart rate is your norm, that's what we're going to do. We see that a lot with thyroid medications when we're testing metabolism, and it's going to regulate your thyroid. And so I always tell people, if your medication changes, the test might change. Like we might need to redo the test. We may need to redo the data. But there's really not that much that we can't handle. We just make sure, again, that they have clearance to do it. That's the big one. And making sure that they're able, that their physician has said it's okay.
I mean, most people coming to us in that circumstance have already been referred by their physician, so they already have clearance, right?
They've already been okay to go. Okay.
And if that's their norm, that's the data we're going to go with for our recommendations.
Okay. So let's put some clarity on, because you guys are in the thick of kind of this big launch of a Metafit expansion, or however you want to see it, but like you guys are really stepping into some very forward thinking, future thinking fields with this. So there's Metafit RX,
Yeah.
I see, fitness, nutrition, behavior. It's a lovely shirt. Tell us about that versus the new stuff that's happening.
Yeah.
Or the RX, the new,
Yeah. So Metafit RX was the original, right? That's our kind of current business that's been in place for about 5 years. That really centers around what we call our core metabolic assessments. That's the DEXA scan for body composition, the resting metabolic rate for your nutrition and for your metabolism, and then the VO2 max for fitness. After that, we kind of saw this need to take it further. People asking us questions about their blood work, asking us questions about their hormones. And so this is where, David has kind of really stepped in and created Metafit MD.
Yeah.
Coming up.
People kept asking us to look at their blood. I'm like, I'm not a physician. I can look at it in the same way you can. And it says that your CRP,
high.
Your CRP levels are
right.
Okay. I mean, I can read it just the way you can, but I can't interpret and diagnose or prescribe. So we looked at it as, one, we were just looking at blood. We just wanted to get the blood work to help enhance. And also because we work with obesity a lot and we work in longevity, for lack of a better word, really, when we talk about just being really healthy, right? How can we optimize our middle to end of life is really how we think of longevity is sleep, diet, stress, exercise, right? There's no secret. But we kept getting asked about it. So like, all right, well, blood is one. And then we kept seeing lots and lots of people on GLP-1s and scanning, doing a lot of DEXAs and tracking people on their weight loss journey on GLP-1s. And then we keep talking to all these people who are like, oh, I can't sleep. I'm having all these issues. I'm like, so I got tired of hearing about it. And but it's very real, right? And the symptoms that occur to women are very real. And we kept hearing dismissal by the traditional medical practices, not by the better physicians that we work with, but by, frankly, more the larger systems that don't have time, not coming from concierge or direct primary care, who we partner with a lot. It would come from the big systems that are insurance-based that have 5 minutes with the patient, right?
Right.
So, and they're like, oh, honey, you're just getting older. Sorry, Camille.
Yeah.
You just have to deal.
Take some birth control.
Right. Here's some birth control.
Well, and it's also like it's the shift in conversations around perimenopause and menopause. It's not just a shift. It is a fully different vehicle we're in now.
Well, you had a complete reversal on hormone therapy in the last year, right?
I mean, 3 years ago, a patient with chronic elbow pain and we couldn't solve it. And now I'm like, oh, go get your hormones checked. Go get on estrogen, go get on your hormone medication, and boom, elbow pain gone.
Right.
It's a whole different level of awareness, and it takes 10 years for everything, right? Like for medicine to catch up. It takes, and those big systems don't have the flexibility to make that shift. Yeah.
And there were some people we were seeing with our testing, it was just out of our scope. And like, we need this step with the physician. We needed to be able to combine what we do with what a physician can do to do what's best for the patient.
Yeah.
Right.
And then adding in, we're looking from that longevity perspective of muscle health and sarcopenia and total muscle mass, visceral fat and total body fat, bone health. So now we're doing the diagnostic bone scans also. It's not a primary, but a diagnostic bone scan for osteopenia porosis, diagnosable, is what we can now write the order and fulfill and have our physician hop on a call. And then our goal really with MD, though, is to get you to a good primary care doc. So if someone decides to do, the way MD will kind of work is you must do RX testing. It's a requirement. DEXA, RMR, VO2, blood test. That's the baseline. Bone test also included. Then from there, you have 3 options. You can either, depending on what the results of your blood testing, of your RX testing, the consultation with the physician, your symptoms, it's super nuanced, right? This is very nuanced. Hormone therapy may be an option, or GLP-1s may be an option, or both may be an option for somebody. So it depends on what they need. And then from there, we give recommendations, but we're really talking about, we talk about this a lot, about patient-directed care or self-directed care, which can sound a little hacky, but what we really mean is working together so that we present the information to the person and they can really take control of their health and say, look, this is what we recommend. You don't have to do it, but this is what we recommend. Or if they say, hey, I really want to get on testosterone, but we look at everything, the symptoms aren't there, the blood work doesn't support it, behaviorally, we might say, look, we get it, but we don't recommend it at this time. So there are other people also who will prescribe anybody testosterone who walks in the door, and we won't be doing that. We'll only do it when it makes medical sense, right? And it's not as simple as a blood test. So us having this complete battery of testing the way that nobody else does really gives a big advantage to look at them in a very holistic way and all the cardiometabolic markers that no one else is simply providing, right? So
that patient experience is they come in, they're like, I want to do all the things. I want to live forever.
Yeah.
I want you to like scan me head to toe, like stick me in the scanner, take my blood, do all the stuff. So they come to you guys and that's what they're doing in your space, but they're not seeing an ND in your space. Is that right?
Probably telehealth.
Okay.
He's virtual.
Okay. He's virtual. Okay. So you guys are the implementers, and then you still have that MD level coming in to say, okay, this is what all the data is saying. And they are saying, these are the prescriptions, these are the actions.
Right.
And then you guys don't stop there. You don't stop that relationship with that person there. So like, tell me more about that.
Where that will work is from there, they have, if all they needed was like you came in, right. And you're good. Your VO2 is superior. Your body composition was perfect. There's nothing to improve. You're obviously a specimen, right? You know, how do you improve perfection, right? So you would be.
That's what I say every day.
Right. We did all that. You want to do your blood testing because you want to be preventative. So now you have a metabolic plan that we lay out for you to say, here, Camille, frankly, the answer is keep doing what you're doing. But if you want to improve it, here's what we also recommend, right? And we'll see you in a year, right? But now you're also having symptoms of perimenopause, and through your discussion with Dr. T, ironically, his name is Dr. T. But you uncover, hey, you actually are a good candidate for HRT, right? That hormone replacement therapy could be a good option for you. Now it becomes different because now we need to monitor you, right? GLP-1s are not a good option for you. They're not needed. But HRT could be a good option. You decide to do it. We write the script. You fill it. We do not sell the medication. Do not provide any medications. We write the scripts. We don't draw the blood. We'll send you to LabCorp. But you will get onto a monthly subscription at that point where we will continue to monitor and through any tests that we need, whether DEXA, RMR, or VO2, you would have behavioral sessions with me. You would meet with a physician, and we have the ongoing medical support team in a way that, again, nobody else provides. And that would be a 6-month window. And then from there, hey, I'm doing really well. You know, we've now connected you to a PCP who can just prescribe this for you. You don't need to be spending an extra fee with us. Just come back, see us when you need us, and graduate from the plan, kind of. I made it sound kind of weird, but the goal is to get you hopefully in that place where you don't really need us as high of an intensity. Now, if you don't have a doctor who won't prescribe, it's a different story. And you don't have a physician that won't prescribe or understand this or whatever it may be, that's where someone may stay on it. And it depends. It's really individual on the person. What do they need? How long do they need it? And again, we really want to team up with people that are good PCPs to handle this. So they're just coming back to get a scree scan, or if they just enjoy working with us too, they can stay working with us. But it's very much driven by what you want to do. There's no pressure to do it whatsoever.
A big component that he said, the behavioral change, the behavior piece, that's actually a big piece that brought us into business together, because I am the lab rat, right? I do all the data, I do all the testing. But what we found out pretty quickly was, I hand you the answer, and then a year later you haven't done any of it, and you and I just stare at each other like, well, why haven't you done it? And so there's so much more than it's easy on paper, right? But applying it in real life for everybody is so different. And that's where his background came into play. So I'm a clinical exercise physiologist. I'm like, here, go do. And, your life gets in the way. And that's where, behavior change for people has been such a massive part of this, because none of this matters. None of the cool data I give you matters if you're not going to apply it and if you're not going to do it. So that was honestly what brought us together in this business, was the fact that, I can give you all this stuff, but if you don't know how to change your behavior and make those habits and, slowly work towards a healthy lifestyle, what I hand people on paper is perfection. You probably can't go do that tomorrow. You probably have to implement it slowly. So that was a really big piece, was kind of bringing in that coaching. So we have, we have options for that. You can come in and get the stuff and be on your way, or you can do the accountability and the coaching and the behavior change. So that just alerted me that, that was a big reason that we got into business together, was because of his background being in the behavior, with my background being in the physiology, and they don't really work without each other. So together it's been a good
so it's like we literally have the art and the science,
exactly
here and together.
You need them both.
And you need them both.
That's, I bet if by the time I finish interviewing all these wonderful, brilliant, expertise-minded people around, that's always going to be what comes out. Like the people who are actually quite good and quite passionate about building their community and truly helping people are really interested in putting some art and some science together, and I think it's really neat to see how you guys are doing this in this very highly specific way, that while maybe it was slow to start, I feel like it's super future thinking. And it's trending that way, right? Like more and more people are starting to understand that they want to be seen as a whole person. They don't just want a VO2 test. They want a VO2 test and their blood work put together, so that's known. They want to talk to someone about how they feel about it, and then they want a plan. So how do they tell me about that behavior and plan piece. How about that year in between? What's happening?
Yeah. So again, that's kind of up to the individual, right? I will say some people come and get this stuff and they're good to go, right? They're self-driven. We're going to see them in 6 months and we're just redoing the testing. If that's not you, we have a membership option that's basically coaching, and you can check back in on the machines. David is the health coach. He'll have the conversation. Typically, sleep, diet, stress, exercise, repeat. What's going on in your life? What are the barriers that's causing you to not make those behavior changes that you want to do? And it's as counseling as you can get without therapy, right?
I know where that line is, right? And this is the reason why I'm always reaching out to mental health clinics to say, hey, so mental health clinics and dietitians, because there's everybody I talk to, I end up doing coaching with, one question I'm asking is about, are you seeing a mental health therapist, right? And a lot of times people are, and it very much can straddle that line, but I stick to those 4 areas: sleep, diet, stress, exercise. And once it gets to things that I'm like, this is out of my scope, I want you to talk to somebody, right? And I'll work them out. The same with dietitians with eating disorders and disordered eating. We have a dietitian that we work with who we write under, Stephanie Mall, who was my sports nutrition professor from grad school. She's up in Nova. But we also have Nourish to Flourish, which is by you. NTF has been fantastic. We've sent a number of people to them. Stephanie Militano, who's a sports dietitian for young female athletes. She's all online. She's out of Williamsburg. She's fantastic. So we always want to send to the appropriate provider for what they need. If they want in-person, if they want insurance-based, cash-based, it really depends on what their needs are, and we send them to the best person for what their needs are. And what, maybe it's not our dietitian, maybe it's Stephanie or it's NTF, right? And it really depends on economics too. We had a woman call it a day that was asking about our services. I told her how we don't take insurance, and long story short, referred her to NTF. And she was so blown away that I was going out of my way to connect her to a provider. She's like, I'm not going to come see you. I'm like, but I want you to get into the right hands of someone that can help you. And that's what was mattered, was there was she's not coming, she can't afford the testing, right? So, but she needed someone to cover her insurance, and they do. So it's, help turn into a perfect fit, right? She wins, right? We have a great referral. We're able to pass, and she wins. She gets the service she needs. And so it's a win-win, if you ask me.
I agree. I think that there's a big difference between feeling like you're the expert that can give your patient a great experience versus does the patient get a good experience with an expert? And I think anybody worth their salt in the health and wellness field cares a lot more about that. You get to somebody, and you get to the person who's going to help you and that you want help from. And if that's because you need to go through insurance, you need to go through cash, or you need a female, or you need a male, or you need a big gym or a tiny clinic. There's plenty of people that you guys I want you to come see me, but you're like, Are you going to go to a nutritionist? Like,
Right.
let's start there. Like, let's
Yeah.
get you to somebody and let's get you to the right fit. So it's, I mean, everything, the way you guys describe your clinic, it sounds so much, I think where it's almost hard for the rest of us to like take a bite out of is you're almost like a primary care. Like you're like a triage. You're like, I know you're not, but like the point being is in like how it's better to think of like a family physician or a triage situation is they are not the ones actually implementing everything, but they are the first tier. They're the ones who open the door and say, this is the path you need to go down. And this is who you can call. Right. And that's what I mean. I know it's not, you're not the primary care, but just you triage people with data and you say, these are what you need. These are the ones we can help with. These are the 3 other providers who I want you to talk to.
Right. Yeah. I would say we're not primary care, we're practical care, because the idea is in primary care, you generally get a blood on your annual. I talk about annual physical a lot. You get your blood panel and the doctor, okay, you're great. I'll see you next week, Susie. You know, like I'll see you in a year for your annual. But where's the practical? Where did you test my strength? Which we're also adding that through Evolve performance testing systems. So we'll be testing some strength metrics now too. So when we send it out to a PT or a trainer, hey, by the way, we have some baseline metrics here that we have normative data and comparisons on, and their balance they really need to work on balance, and we can do really cool stuff. That's a whole other conversation. But testing strength, something I was going to tell you about is we want to start to integrate an MSK screen to an annual physical. We envision a physical as being blood, MSK, strength, all of our other testing, and a mental health eval, really, right? And then on the back end, you have a physician who talks to them and takes all this data and puts it together. And they provide that as part of with the blood. You have all these other providers come together and you have a powerhouse of information. It's not just, oh, your blood was fine and you're good. I mean, your blood doesn't lie, but your blood doesn't tell the whole story. It doesn't tell you if you can pull yourself up off the ground. It doesn't tell you if you have good balance. It doesn't tell you what your visceral fat is. It doesn't tell you what mobility is. It doesn't tell you if you can do your ADLs. It doesn't tell you any of that. So there's a lot lacking in your annual that I think is really incomplete. So we're kind of forming what we almost call it an executive physical, where we have other providers do the parts we don't do, but they're integrated into the offering because they're really, we believe like what you do is super, an MSK screen is super, super important.
Yeah.
Really, really important. And especially for like an old man like me, it's like everything just hurts now. Nothing moves. Like, 24 is different. 48's different story.
It's a different story. Yeah. Those we underestimate MSK screen. The rest of the world does. MSK screens have been certainly part of they're what got me in trouble in the first place, right? Like I was perfectly happy to be a pretty standard corrective exercise specialist, as a personal trainer. And then I started really getting into that functional movement screen world and the overhead squat assessment and like all these assessments. And certainly, when you do that, you swing too far. And you get like hyper corrective and you get hyper neurotic and everything is form and technique. And then eventually you soften back to like humans are organic and they can move. Yeah. But that screen is so powerful for just giving you a snapshot of like, this is where you are.
Right.
And but my shtick with people is always been like, well, the screens don't work. It's like, but you didn't ask the next question. Yeah. Right. You saw that they couldn't do this or they could do that or their knee did this or their elbow did that. Yeah. But you didn't then ask the next question, which is why?
Yeah.
So where do you take those screens next? Like where do you go with the why?
Right. Yeah. And that's why I think it integrates really well as part of this comprehensive. And like a screen on its own can be hard to get someone to do, convince them why it's important. Right. But when you look in the totality of some strength testing and body composition testing, and you find out, I'm not going to say their name, but we have one person who's a former professional athlete.
Physical perfection.
Yeah. But the man can't touch his toes.
Can't touch his toes though.
Right.
So body fat's perfect.
His biggest area he needs help is in that screening for his mobility and flexibility. That's where he could show demonstrable improvement.
Right.
And otherwise there's really not much else to improve on him. It's just maintenance. But that's an area where something like that could use major help in that way to help him take that next level.
I mean, mobility and flexibility
for these males.
Completely lost on this person, you know, and that's a massive thing. So you have all this muscle, you're in great shape, but you're not gonna be able to move it in 10 years if we don't, you know, fix it. There's always something, right? There's always something that we can help improve upon, and it's not always something we can do. So being able to have, you know, that comprehensive care.
And that's how
you guys do have a trainer on staff though, right? Or do you don't anymore? Okay. So you refer out for any kind of fitness, like people aren't working out. They're not coming to your place to work out.
No, I mean, we all have personal training backgrounds, but we refer that out just because we have such great relationships with personal trainers, and it's just so much better for us to do the testing and then let them do, you know, that type of program.
Do their thing.
Yeah,
absolutely.
That's the advantage you have there by doing kind of a hybrid model, right? And your background with training and a therapy, like it's a good company, because that's where you see personal trainers going to go to. Do they do they go on to become a DPT, or do they just maybe get into strength and conditioning?
Right.
You know, they get into rehab. You know, what do they do? Or just stick with personal training and Gen Pop. So it helps tremendously, because putting people under load is risky, right? So you need to make sure they don't get hurt, and that's where you have that big advantage in that way.
And what we're seeing now, certainly our clinic gets a lot of it, and I think it's in part because of the conversation trends that are out there in the world right now, as well, and our awareness. And then also just because I like the weird problem, so I don't get straightforward orthopedic. I always get something where it's this like weird tangled mess. Is that it's always there's always some element of like a dysautonomia, some kind of sympathetic nerve system issue, or they're on a hypermobility spectrum. Like there's something where there's more complexity, something where their body is in some way inflamed because of lifestyle, because of a disease, because of whatever it is. So I'm really intrigued to see what it will be like to move forward in physical therapy if we have organizations that are giving us those kind of numbers, if we're getting that kind of information as part of the picture. Like, oh, you're not in pain because you're in pain. You're in pain because all of these blood levels are out of control, or your VO2 max is, your threshold and your VO2 max are so far apart that you can't tolerate anything. So I'm really interested to see how you guys continue to build your community, your networking, but not networking, your language, or with us, with the other providers that you partner with, to enhance somebody's experience.
Yeah, that's the whole goal, is to enhance outcome, to improve outcomes, enhance the experience, right? And that's where I always emphasize to people, particularly people like, oh, I'm so booked up, I don't need to network. And I said, but you're missing the point. The point isn't to network. The point is the people you see have other needs you do not fulfill. I guarantee it.
Absolutely.
So it's great that your book's to fill it for 6 months. One, what happens? Two, if that falls off, oh, now I need to start networking, but now you're a year behind. But two is you have other needs. They have other needs, I guarantee it. And if you don't ask the right questions, you never discover what the other needs are. So it gives them a better experience. They love you even more, and they get better. Ultimately, they just get better outcomes.
Do you feel like you're catching stuff that has been missed?
Sometimes, there's been some testing that we've done.
Five times we've had it now,
and we can't diagnose, but we're like, hey, this is seriously abnormal. And there have been a couple times where after a test, I have directly contacted a physician and have been like, we don't necessarily know what this is, but here's what's happening. So, and they'll go into additional testing, and bronchiectasis. So
bronchiectasis was one. So we've had it
some
5.
Lung disease.
So so it's bronchiectasis is like a wet COPD. So this is the first time we saw the anomaly occur. I was running a test, and Melissa figured I messed it up. I didn't. We retested this woman.
I thought for sure it was his
default.
fault.
Yeah, that's the obvious default.
Is a
We've
woman.
Never seen this before.
It was a very active woman in her 60s. Luckily, her physician had referred her, so we had an automatic fallback to talk to. But we retested her because when this woman became anaerobic and went for max at the end of the test, her heart rate continued to rise, but her oxygen,
her VO2
went down. Actually went down.
She became aerobic.
So she just thought she was so out of shape.
No.
She was huffing and puffing, and
Yeah,
you would have thought she was running a marathon.
Yeah,
she
was
looked
great.
like she was in great shape. She felt fine,
Probably,
which is why I thought he messed up or something messed up, because I was like, this isn't correct. Her VO2 should not be going down. We tested it again and it went down again. I was like, so now something's wrong.
Yeah, but
like,
her lungs weren't functioning properly to produce oxygen at that point, and they were now taking it away, and it was her heart rate would continue to rise, and then you saw VO2 max go down, where you normally see these linear.
They normally go together.
They go together, right?
So now, her expired gases were not reading correctly, and we're like, so we did it, repeat it, exact same moment where she comes anaerobic, same heart rate, everything. It happened again, and we're like, okay. So long story short, referred her back to her doc. They had found a spot in her lungs almost 20 years ago. It hadn't appeared in almost 20 years. She was asymptomatic. Retested her, did more imaging and testing, and found out bronchiectasis is there. So this woman, by being so active into her 60s, has staved off being on oxygen, basically, because now she'll eventually have to be on oxygen from the disease as it progresses. But she's done a very good job at stopping that from happening, and it's due to her own. I mean, she's an athlete in her 60s.
Yeah. And they had no idea that was even occurring.
They had no idea, because that one anomaly almost 20 years ago hadn't shown up in any other testing, nothing else. So doing the VO2 made it appear. And we've had it appear a few other times, and we had another person that we never found out the outcome, but we had one we need to follow up. This person had a significant drop in his VO2 max 1 year apart. Despite doing those same activities, he had a rather large decrease you would not expect to see, which is not normal. Which we don't know we still don't know what the issue is with that person. But as a result, we now refer them, and then we've seen a couple of times
on the DEXA.
Lymphedema.
So on the DEXA, we've seen fluid where fluid should not be.
Lymphedema.
Well, one was a confirmed case of lymphedema, but one we haven't confirmed yet, and we're not quite sure what it is. And so, again, we can't diagnose, but I'm looking at the screen and I'm like, fluid shouldn't be around your abdomen. Like, let's call a doctor, you know. And so stuff like that, it's rare, but stuff like that does occur where we're able to alert people to something being wrong.
Yeah, that's a big one on the DEXA, is when you see fluid in the muscle, and when someone is 200 pounds and they're 5'2", but saying they're 15% body fat, that just isn't right.
It's because it's reading fluid as lean mass.
And it shouldn't be that way.
Everywhere.
So, and then with metabolism, we've seen it where people can't lose weight on GLP-1s, and you find out that there was a male we had, he should have been around 2,000 calories for his height, weight, age, and sex. He tested at only 1,200 calories.
Very low.
Because he had gained and lost 50 pounds or more about a dozen times. He was always going up and down.
And crashed it.
Yeah, so he destroyed his metabolism. He literally only burned as a middle-aged male over 200 pounds, only burned 1,200 calories a day.
Yeah.
And he could not lose weight eating at around 1,200. He's like, I'm not losing any weight.
But that's his baseline.
So this guy was getting down into way lower had to get down to like 500 calories a day to lose weight.
So we do catch some things, obviously there are some things that we don't know what they are, but we make sure that we refer it out. But sometimes there's a piece of the puzzle like that where, everything should be working, but the math ain't mathing. And they'll come in, it's, something like that, something like the metabolism is slowed down, the metabolic adaptation. We've unfortunately uncovered a lot of low bone density on people that you wouldn't think to go get tested because you're 40, and the sarcopenic obesity has been a big one, which is the fancy term for skinny fat. We'll have somebody come in, they've been told all their life that they're normal because they present as normal on the BMI scale, but they might have 40% body fat, not because they're over fat, because they're under muscled. And a lot of times
they could even be an athlete.
They could even be an athlete. Triathletes have come in and that's happened.
That doesn't surprise me in the slightest.
Right? Their VO2 is through the roof, but they're sarcopenic obesity. And oftentimes that's accompanied by low bone density. We get a lot of ex-swimmers who, again, they had phenomenal VO2 max, but very low bone density. Also, they were never properly instructed on what to do when they stopped swimming. So obesity now enters the category because they're used to burning such crazy amounts of calories when they were swimming, and they went from being an athlete to just being a normal life. And now all of a sudden, you know, that expenditure is just completely off. So we're looking at low bone density, sometimes a low metabolism, you know, and they don't know what's going on because they, you know, used to have that kind of athlete lifestyle and they don't anymore. And it's over time just kind of catches up to them without them realizing what's going on. And then, like I said, having that accompanied by low bone density is we catch that a lot, unfortunately.
Yeah, sarcopenic obesity is a rough one, especially if you're a woman in your 50s who's always been thin, healthy, presenting as normal, where you know, what people, oh, he looks so great. And oh, God, I've never had to work out. Well, there's 100 other reasons to exercise and to lift weights that other than looks, right? But now she's in her 50s. She's sarcopenic. She's no muscle.
She's not metabolically healthy.
Not metabolically healthy. Maybe she has some decent cardio, but it's a thing of, you know, putting on muscle as a woman in your 50s who's never lifted weights. It can be done, but it is hard, right?
It's a challenge. It's a real challenge.
We might even need her to gain weight. And you're talking about, what? You want me to put on weight? And
you want me to eat more?
I went through that with somebody she came to see me because she's probably had sarcopenic obesity, right? Like, you know, she walks 5 miles a day and she's the same weight that she was when she was 25. And, you know, but she has osteopenia. I'm like, great, let's build some muscle mass. And she actually like got repulsed. She was just like, and I was like, I'm trying to save your life. Like,
you know, I thought as a society we were getting better about that, but still, I think a certain age, women.
Well, you can see like they're just in that. Like, I mean, I think the kids coming up now are going to are much better off, and like kind of the young millennials and then the generation under them, they're doing much better.
Yeah.
Right. Especially the girls, but like from us and up, it's like, and especially any like that boomer generation, it is toxic in their brains. Like the very idea of building muscle is like this, like not all of them, but just it's very hard. It's an uphill battle for sure. But it sounds, I mean, it's such a beautiful place that you guys are in of being the ones that actually give data so that goal setting has some clarity around it and has measurable numbers, and people love to measure. And maybe we can start really pushing that into the insurance world. So because insurance wants numbers.
That's such an important one too, is setting a realistic goal. You know, with the DEXA, you know, I remember the first time when I was in college, the first time I got my body composition done and my professor asked me what my goal was. And I arbitrarily said something like I wanted to be a size 2 or something stupid. And, you know, I remember him going through my DEXA and he said, okay, well, we're literally going to have to shave your hip bones in order for that to happen. Like you will not reach that size. And so it's kind of taught us to look at what is your composition, what's your bone, what's your lean mass, what's your body fat? How can we set a realistic goal based on this data? You know, also we really try to relate to people the difference between exercising for health and exercising for the Instagram body. And I think people have that massively mixed up. You know, they'll come in and they're like, I'm walking every day, I eat relatively healthy, where are my abs? And it's like, okay, we're talking about
different, two different goals.
Different ball game here. We're talking about health versus athletic fitness, which is completely different. And you know, Instagram and TikTok doesn't help. You got somebody shredded doing body weight squats, and I'm like, you didn't get that doing body weight squats. So
I know.
Trying to set that realistic target for people. Because they all just have such a skewed view, not only of where they're at, but what's possible to get to.
Right.
And I'm like, look, you can get to that Instagram body, but knowing from experience, here's what you're going to have to do. It sucks. It's miserable, and you're not going to be able to live your life. Like, so just trying to get, you know, that kind of realism and happy and healthy, and what's that happy medium, right? Because it's not that somebody can't do it, but there's really this disconnect between what's healthy and getting to that athlete body. And so many people are, you know, oh, I'm doing X, Y, and Z. They're barely meeting the minimum for health, barely, and yelling at me that they don't have abs. And I'm like, we're talking about two different things here. So, you know, the DEXA is definitely great for helping set those realistic goals. What can you achieve with your body type? What are we looking at that's healthy? And that can be really important, because I think a lot of people, you know, myself included, before I got into all this, was like, here's my arbitrary weight goal. I want to be 125. And it's like, not going to happen. You know, I'd be 0% body fat in which everything would shut down. So it just wouldn't work. So we've really tried to be realistic, but be realistic in a way that it's going to make you happy and it's going to make you feel good. And how do you feel? And, you know, making the data a little bit more realistic for people.
Yeah, well, I'm so glad that you guys are able to be such a strong resource in our community. And it's been really beautiful watching you guys focusing your community building around the providers, or, you know, there's just not a lot of people doing that, and it definitely needs to be done. So I always feel like if I need a name, I'm like, let me call David, let me message David and see like if he's got a good person for me. Does he have like the person I need? And it's like, it sounds like you've actually had to, because you're leveraging all this data and you're leveraging this customer experience. So thank you for your service. Continue to build this amazing Richmond community for us. I think that's wonderful. Yeah. So I think I'm going to end it there, because we could talk probably for another 2 hours. And I feel like I have more questions, but I think what you've done today is help me and my patients understand that they do fit in this testing world. It will create a more effective and efficient plan for growth and change. So thank you. Is there anything else? What final thought do you want to share with the world?
Oh my gosh.
Internationally famous podcast.
Our final thoughts.
Trying to see if I took any notes today.
Yeah, other than like kind of how we started, this is for everyone, you know, and I feel like marketing 101, like that's the worst thing you can say, is that everybody, you know, there are it's everybody, but it really is. I think that everybody in some way can use this data. I really think it's helpful. And I really think that we have positioned it in a way where it's accessible to everyone, and where we explain it to you. You don't just leave here, you know, you're going to know what it is and how to use it, and hopefully, you know, help make changes for the better.
Yeah. It's the practical care component, which because of you, we've now coined that term as practical care, but
I think you should.
I think it makes sense, because I've always had an issue with the standard annual physical not being, it just lacks so much, right?
Yeah. I think you're for anyone who wants clarity around their metabolic status. Yeah. Right. And I think that covers a lot of territory, and I think everybody has a metabolism. So it's for everybody. Right. In theory, we all have one.
It's there. How it's working, that's another story.
That's another question. Well, thank you guys so much for your time. I am looking forward to getting this out there and sharing it with my patients. And I am looking forward to talking with you guys again in the future. I definitely have someone tomorrow that I will be passing your information along to. So awesome. All right. Bye, guys.
Bye.
Thank you so much.